So our next presentation is equally exciting as the first two, and it's going to address a topic that's very important to all of us, and that is substance use disorder patients, opioid. And one of the things that this team has been focused on is addiction. Their work has reached the levels of the White House. We're very impressed with them. They've represented Christiana Care very well in their collaborative efforts. And their objective was to come up with a very easy-to-use, validated opioid withdrawal screening tool, which would help as a cognitive aid for providers at the bedside. So I'd like to welcome Dr. Horton and Claudine Jurkovitz. Thank you.
So thank you. First, I'd like to say I have no disclosures, but I would like to say thank you. Thank you because for the last 10 years, I've been able to work with my colleagues in the VI and its predecessors, and I was given the opportunity to tap into their resources, often for free. But really, without that, we couldn't have done anything that we've achieved with care of those who are alcohol use disordered and as well as opiate use disordered. We've been able to create a whole body of effort that other institutions are borrowing, and we're happy to lend that to them. But it really required the ability to tap into my colleagues like Claudine, who could provide us with the rigor of methodology and a robust assessment. So ultimately, some of the crazy ideas that we'd come up with, they could actually show that they worked. So for that, I'm eternally grateful. Today, we're going to really talk about one small effort, which is, I think, very important because hadn't been done before, which is to screen for actually the risk of opiate withdrawal in an inpatient hospital setting. And I will speak why that's important, and then Claudine will tell you about the meat of the effort that we achieved. Essentially, we're in the middle of an opioid epidemic. You just have to pick up the paper and know that this opioid epidemic, particularly since 2014, the death rates have superseded amazing things, really. Peak gun death rate, peak HIV death rate, something I never thought I would see as a resident who worked in New York and at the peak of that HIV epidemic, peak car crash deaths. So that's what's happening in our community. People are dying. And as a health system, when our doors are always open, and individuals who are opioid dependent, when they use, and by the way, they're using intravenous needles primarily, and they're using very high dose heroin. And when you use high-dose heroin and you use intravenous needles, when you get sick enough to come to the hospital, it's usually fairly catastrophic. And so they're coming at our emergency room and our inpatient, not only ours, but all across the country at much higher rates than ever before. And they're coming with really serious conditions like right-sided endocarditis, which we hadn't seen in a while, septic emboli, spinal infections, things that, with 6-week admissions. And when we look at, what can we do about this? We really need to look at the condition itself, and it's that the driving force in opiate addiction is actually opiate withdrawal, which is a neuromaladaptation. There used to be thought of opiate withdrawal is just like the flu. It's not. It's a neuromaladaptation that a whole set of conditions occur that ultimately results in a primal misery. And I heard definition of value being, what someone considers an outcome. And if you're opioid dependent, it's that opiate withdrawal and the inability or not having it addressed. It says to you that system doesn't have value and they're not going to take care of me. And that, unfortunately, had been the standard of care for decades. And it's not, when you have a condition that like that and you can't engage those individuals with serious disease, or you can imagine what the outcomes are. So opiate withdrawal is a highly motivating condition, but we actually think, our theory and our hypothesis was that we could actually use that as a lever to engage individuals. Again, if you don't engage those individuals, what do they do when they end up in the hospital? They didn't have a planned admission, by and large. And this isn't just our problem, this is all over the country. So they do what folks do when they're going to take care of themselves. And they'll use heroin in the hospital, or they'll just simply leave. Again, that was tolerated for decades. But effectively, what that when someone leaves against medical advice, you're not able to attend to that serious health condition that brought them in the first place, and they tend to readmit twice the length of stay, twice the care needed. And it also, you lose that opportunity to engage them and address the root cause issue that brought them in the hospital in the first place. Again, that was a standard of care for decades. And the opioid epidemic has really driven home to everyone that we need to change that. So at Christiana, we had this terrific opportunity to do something different. And it started with the opportunity for the opioid pathway was based on our challenge to create pathways several years ago here at the, across all the different service lines. And there was quite a bit of enthusiasm to do something for those who are opiate dependent. So the basic mechanism for our pathway is to start screening. You have to identify individuals. How do you do that? Embed that work in our EHR, and then provide opiate withdrawal treatment rapidly. So we're going to screen for and then treat rapidly. And our theory is if we screen for, identify, and treat rapidly opiate withdrawal, we're addressing the individual's root cause issue, their primal misery, value to them, they don't leave, we can address their issue, and maybe we can actually engage them into care and address, move on and to attend to addiction. And so we're not going to speak about the results of all that work because that's sort of ongoing, and I can tell you it's some of it's kind of exciting, but critical to all of that is the starting point. And the starting point is really the ability to screen for. So when we started this work, we had a large group of people. We said, well, how are we going to find an individual's in opiate withdrawal? Well, is there a screening tool? No, there wasn't a national screening tool. And we did the lit review, we spoke to the National Institute of Drug Abuse, and no one had a screening tool. So in this environment that I think the VI fosters and Christiana fosters, we had kind of can do, we said, well, we'll create one. We'll make it up, and let's go forward. It's not enough to make something up, though. You really do need to have something behind it and be able to assess, have you caused harm? Have you done anything? Particularly when you're going to ask grandmom if she uses heroin when she gets admitted to the hospital, which is what we propose to do. So the basic screening tool that starts off, if you're admitted to this hospital, is you get asked two questions. Do you use prescription opiates or heroin other than prescribed over the last week? And do you get sick if you don't use those? Two questions, simple screening tool. And if you say yes to either of those, a whole nother set of processes go into play. You're screened for opiate withdrawal, and then hospitalists are made aware so that they can offer treatment. So again, it all starts with the screening tool, and is it valid, does it work? And as you can imagine, there was quite a bit of skepticism, like who's going to admit to using heroin? And is grandmom going to get really angry if she's asked such an outrageous question as she used heroin? Turns out our record actually is a 94-year-old who abused Percocet. And I can tell you that we have a large cohort of 60 and above who actually do use heroin. So I'm going to turn over to Claudine so she can tell you about the efforts.
Thank you, Terry. Thank you very much. So Terry, in fact, designed this screening tool, and we were here to validate it. So our objective was to evaluate the accuracy of the risk assessment tool, which is the ORA, in identifying patients at risk for opioid withdrawal. And our instrument, as Terry described, is the Opioid Withdrawal Risk Assessment, again, or ORA, our tool. Our target population were all adult patients admitted to the hospital medical services between December 2016 and October 2017. And we were very fortunate to have some funding support from Dr. Hicks' CTR Axel Fund, as well as from the Department of Medicine. So the ORA, as Terry mentioned, the ORA is now in the electronic health record, as well as the instructions and the preamble. So when a patient is admitted to the hospital, the nurses are prompted to administer the aura and to inform the patient that questionnaire care has a new pathway to address opioid and heroin withdrawal. The preamble that is suggested is, I am now going to ask questions to assess your possible risk of withdrawal, and this is all in the electronic health record. So this is what is in the electronic health record. The two questions that Terry mentioned: have you used heroin or prescription pain medications other than what was prescribed in the last week? And do you get sick if you can't use heroin, methadone, or prescription pain medications? And a yes answer to any of these two questions identified the patient as at risk for withdrawal, and promotes and targets the administration of the COWS, so another abbreviation here, which is a clinical opiate withdrawal scale. This is a validated instrument which was used, or which is used, to monitor opioid withdrawal. And it has 11 domains. It explores 11 domains: resting pulse rate, sweating, restlessness, pupil size, bone or joint aches, runny nose or tearing, GI upset, tremor, yawning, anxiety or irritability, and gooseflesh skin. Each number associated with all of these domains are scored into a total score, and this score is stratified into 4 categories of severity of opioid withdrawal. We choose, with a pathway, a score of greater or equal than 8 to positively identify opioid withdrawal, and we chose 8 with the goal of decreasing the risk of false positives for the COWS. So how does it work? The aura, as mentioned before, the aura screening tools is administered to all patients admitted to hospital medical units, and this is part of the pathway. This is what is done now. Patients with positive aura screening test enter the opioid withdrawal pathway, and then the COWS, as mentioned before, is administered by the floor nurse per the pathway. However, in order for us to validate this instrument, we needed also to administer the COWS to the patients who are aura negative, so for whom the screening tool is negative. So what we did, and that was part of our research, we had several research nurses and per diem nurses who were specifically hired for the validation project, who received a list 3 times a day of all the patients who were aura negatives, were screened negative into by the screening tool, and they went ahead and administered the COWS to a number of patients who met all our eligibility criteria. So if the first COWS was less than 8, the assessment was repeated 24 hours later. A COWS score of less than 8 after 2 administrations was indicative or no withdrawal, so the patient doesn't have withdrawal at the time. But a COWS score greater or equal than 8 after the first or second administration was considered positive for withdrawal. And that's the same also for the patients who enter the pathway. So here are some results of our study population. So we had a large number of patients, more than 22,000 patients. And to note, before I go there, there was the number of patients who screened positive for the aura, so at risk of opioid withdrawal, is pretty small, 2.4%. However, and there are some interesting characteristics in these patients. They are, in general, much younger than the patients who screened negative. They also are much more likely to have Medicaid, 62.5% versus 16.8%, much more likely to smoke, less likely to be married. Some other results, outcomes. The rate of AMA is low at 1.2%. However, it is really important to note that among those who are aura positive, the rate of AMA is much, much higher, with all kinds of bad consequences, as Terry mentioned, than the patients who are aura negative. The length of stay is also much higher among these patients who screen positive. And among these patients who screened positive, 32.6% had a positive CAOS, meaning that they were in withdrawal, versus 1.2% of those who screened negative. And if you remember, in fact, this 1.2% represents a false negative for the aura. So, and this is also from our sample, so the patients who sampled were negative. So this is driven by a sample of 657 patients, and 8 of the 657 patients screened negative for the aura, but had a positive CAOS, 1.2%. So reported to the total of 22,000 patients, it's a little more than 200 patients. So these are the false negative, as I mentioned before. So the goal of our project is to determine the sensitivity and the specificity of the test, of the aura test. So just here, I just wanted to remind you of the definition and how we do determine the sensitivity and specificity. So the sensitivity, among those who are CAOS positive, so among those who are at risk for withdrawal, it's the total number of true positive over the number of true positive for false negative. And it is important to know that a test which is highly sensitive has demonstrate low false negatives. The specificity is the total over those who are CAOS negative, so who are not at risk for withdrawal. It's the total number of true negative over the false positive for the true negative. And a test which is highly specific shows a low false positive, and this is important. So it's the results of our test. Again, the table of sensitivity and specificity. We found a very high specificity, 98%, so a low rate of false positive, with which we were very happy. However, really our heart sank when we saw this sensitivity at 39%. So that means that we have a high rate of false negative, meaning that there were lots of patients who answered no to the 2 questions, but in fact were CAOS. And remember, it's these 8 patients, and to the total patients, it's around 250 patients. So what we realized, or what we noticed, however, and in fact the nurses noticed that what they told us, is that many of these patients, many of the symptoms of the domains of the CAOS were very similar to patients demonstrating alcohol withdrawal. And we measure at Christiana Care, we measure alcohol withdrawal with an instrument which is called a CIWA, and I'm sure many of you are familiar with the CIWA. So what we decided to do was to exclude the patients who were in fact in alcohol withdrawal, because that could hide, the opioid withdrawal. And we found a sensitivity of 48%. So this is still not perfect, but it's much better. And in fact, what we think is that, again, the symptoms of opioid withdrawal may also are similar to some symptoms of other disease, such as infection or diarrhea. So we are in the process of doing a very thorough chart review of all the patients who are CAOS positive. And in fact, what we've already found is that of the 8 patients who were aura negative and CAOS positive, 4 had also CIWA positive, so these were the patients who were excluded. And of the 4 remaining patients, we did a chart review of these 4 remaining patients, only one was in fact a true false negative, meaning that the other ones had symptoms such as diarrhea or something else for totally other reason. And if we do a quick analysis, we redo the analysis, we have in fact a sensitivity which is above 70%. So what we are doing now is that we are reviewing all the patients who are CAOS positive to review the symptoms, and we really strongly believe that our test results will have a sensitivity which is above 70%. So we will complete the validation project also by evaluating the outcomes of those screened versus those not screened. And our main outcomes is the time to withdraw treatment. And as Terry explained, this is extremely important to avoid AMA. The rate of AMA, obviously, and the readmission. And we are exploring ways of improving sensitivity by changing the aura preamble language. And we would like to reevaluate the aura after changing the preamble language. And finally, I would like to thank a lot of people, and it has been an extremely fruitful collaboration between the Value Institute, the Behavioral Health Service Line, the Department of Medicine Service Line, Data Informatics and Analytics, Pharmacy, and Nursing. And we were very grateful to have all the many per diem nurses who were extremely instrumental in doing all this work. And I would like also to thank Terry for his continuous enthusiasm and his passion for really improving the care of these patients and his multiple ideas that we are testing all the time, and as well as, as Dr. Jackson for his leadership in the Value Institute and for enabling us to do all this work. Thank you.
Thanks. Great talk, Terry. I'm going to ask you a provocative question. So I really liked how you framed what the patients that we're serving in this project define as value, addressing withdrawal. We know that a lot of times it's avoiding withdrawal that's driving a lot of decision making. So with that said, should we try to move this even further upstream before patients end up in our hospital? Consider things like safe injection sites.
Well, actually, I just came from a really provocative talk in Philadelphia at Jefferson, where they looked at the literature. And of course, the literature is not in the United States, but across the world, where safe injection sites, which are a form of harm reduction, are showing positive effects when you look at community-based metrics. So I think it's worthwhile to think about on a community stance. But I would pull this back to the hospital. I mean, at the end of the day, these patients are they come in, and we need to attend to them here in our hospital and be able to address what's important to them, and then try to figure out ways to do that. So I think by the AMA rate is kind of core, but also we came to realize that other metrics like patient satisfaction, they actually. There's a lot of mythology around this population that they don't participate in, in usual activities like returning their surveys. But in fact, we previously looked at 87 of them 2 years ago did, and they were really unhappy. And you can't become a 5-star if you have 1 stars from a significant population of folks who are returning their surveys. So we were able to actually. And we're going to look at that to see if we can impact that. And the reason those are really important is because you can, as you define that, you can create value for looking at and taking care of a population. You can have adoption across the spectrum. So as opposed to going out into the community in ways that I can't impact at this point, I think where Christiana's niche is really defining the care in the hospital, and I think we've been able to make some inroads.
First, anyone who has been engaged in this clinically on the clinical side, I think it's important to note that the real labor is done by the nurses, Terry and his team, which has been phenomenal in terms of addressing the care for this very large patient population. And Claudine, I think these are excellent analyses. My question, if you could go back to the last slide, is about the false negative patients. And even though in some secondary analyses you've looked to see whether or not this was SIWA or something else, or alcohol withdrawal leading to the positive CAL scoring, were you able to examine whether or not those patients who were negative and then ended up withdrawing in any other way look like the population of patients who were aura positive? In other words, is there something we can learn from either their demographics or their clinical comorbidities, whether or not they're on certain pain regimens, that will lead us to think a little bit more, a little bit harder about when this patient's saying no, should we really still be putting them on CALs?
I mean, I think the problem here is that we have only one patient really who is a true false negative, meaning that the patient said no and he really want to withdraw. And I think Terry can comment on this patient. And just a quick comment. The problem is that we have a sample, so we cannot add, all the other comorbidities and all the information, to do a true model, because we don't have this information for all the 22,000 patients, for whom we don't have a cause. So the modeling is a little tricky. However, also in terms of statistical analysis, what we did and what Rick did was we are using a Bayesian approach to calculate the confidence interval around the sensitivity analysis, because it's a sampling. So it's really neat analysis. I'm very excited about that.
So a little different answer in that a couple things. One, I was actually, when I first saw 39%, I thought, my God, we picked up nearly 1,500 people who are opiate use disordered, and we only have a 39% sensitivity. That's remarkable. That mean, and so there are individuals out there who come in who are not disclosing. They don't know our system. So our theory was, well, maybe if we tell them that we're really here just to help you address your opiate withdrawal with our preamble, it's a simple method. Could we improve upon that? And then when I started doing this chart review around who are the false, to your point, who are the false positives? And there is, and sort of like the CIWA, we know that if you're septic, for example, you can have a CIWA score. But you need to be smart enough. So that we need to be able to learn about that group to be able to educate the hospitalists so they can use that metric and say, wow, that's really interesting. There's a positive withdrawal score, and yet I'm not sure they're in withdrawal. Maybe they're septic. So I think that it's a really good point. And we're actually pulling in family medicine residents going to be assisting us in doing some of that work, and we're going to add that into it.
Dr. Horton, I've worked with a lot of these patients in the past, as you know. One of the things that seems, and this is purely anecdotal, but I've worked with enough of them, but one of the things that seems to be common is that these patients tend to be very sophisticated street pharmacists, in a sense, and know what works for them and what doesn't work for them. And I've encountered a lot of them in the hospital here and say, oh, that's not going to work for me. And they know what's going to relieve their discomfort and what's not. Is there any way, do you think, that can be incorporated into some kind of a screening tool, is asking them what works for you in terms of pain relief? Because if you're giving them an oral medication, they're saying, this is not going to work for me. I need to, they'll say, I need dilaudid, IV dilaudid.
Yeah.
That is a very clear sign that someone is very sophisticated with their opioid use.
Yeah, so like a third question, do you have a suggestion about something that would help you?
I mean, it sounds silly,
it's sort of a trick question, right? We haven't thought of that, and it's interesting. I'm actually intrigued by how often people are very forthcoming with opiate use disorder, as opposed to alcohol or benzodiazepine use, which they're often frequently not as disclosing. And in fact, I usually teach the residents, what's the best way to identify opiate withdrawal? Ask the patient. And they typically will tell you, because it's primal misery, and they really don't want to be in it, and they will do whatever to avoid that, and they really don't want to leave the hospital. So,
thank you.
All right, well, thank you very much.